I'm very pleased to welcome our speakers today. And our speakers are Marianne Novak, and Marianne is a consultant in neurology at St George's in London, and Nayana Lahiri, Nayana is a consultant in clinical genetics also at St George's, and they're going to spend the next hour or so talking about how we support people who are in families where there's Huntington's, because I'm guessing if you've joined the webinar this afternoon, you're aware that it's quite a complex disease to support people with, and hopefully we're hoping today's webinar will help you navigate that a bit.
Yeah, absolutely. Thank you. Thank you, John. So thank you. Thank you for everybody who's attending. And thank you to John and everyone at the HDA for giving Noina and I the chance to talk, because it's a really exciting opportunity for us. To start with, what we'll talk about is to give you an overview of Huntington's disease, then talk about how we can treat it and how we can support patients and families. And then Noina will take over from me and talk about predictive and diagnostic testing and give a brief outline of family planning options. And then we'll have time for questions at the end. So let's start with a broad overview. So just to orientate ourselves, HD is an inherited neurodegenerative condition. Noina will talk more about inheritance. It's the commonest rare disease in neurology. So there's an incidence in the UK of around 1 in 10,000. HD has a main triad of symptoms. It causes a movement disorder, a cognitive disorder or dementia, and a psychiatric disorder. And in addition, there are metabolic and endocrine changes associated with it, including weight loss and altered sleep. There isn't a cure for HD yet, but there's a really active research community in HD, and lots of patients and family members will be active in that. So that's an important thing, I think, to be aware of. However, there are lots of things that we can do to alleviate symptoms, and there are additional ways to support people with HD and their families, and that's what we'll talk about. So this is a slide that Noina will come back to. In fact, I've pinched this slide from Noina, so thank you, Noina. But this represents really what happens in the HD disease process and actually any neurodegenerative disease process. So the horizontal axis is time, and you can see in the yellow line, people who inherit the HD gene start with healthy neurons, and then over time, the neurons start to degenerate, they struggle to function properly, and then ultimately they start to die. And in parallel, people who have the HD gene will start by being entirely asymptomatic. Then they will gradually start to develop some soft symptoms of HD until they reach the point when things really escalate and they will be diagnosed with manifest HD. So thinking about progression over time, we can break things down into a few stages, and there aren't any absolute criteria for each stage, but it's quite helpful to have these terms to roughly orientate ourselves, and they'll come up within what Noina and I are talking about. So we have pre-manifest HD, which are patients or people who carry the HD gene but don't have any signs or symptoms of HD. Then there is prodromal HD, which is the stage where people who are pre-manifest HD gene carriers start to develop some soft symptoms. And then we reach manifest HD, which is defined as when people have developed definite motor signs of Huntington's disease. And then manifest disease can be subdivided into early disease, moderate disease, and advanced disease. So thinking a bit more about the symptoms themselves, first of all, a movement disorder. Well, we know that as a mixed movement disorder, which basically means a real old combination of different symptoms affecting people's movement. So we can subdivide that. HD causes added movements, so chorea, which is the sort of wriggly, dancey type movement that's really common in HD. Dystonia, which is muscle spasms, and tics and myoclonus, which are the jumpy, fast movements. And then people also experience reduced movements, which very broadly look quite a lot like Parkinson's disease with rigidity and slowness of movements, bradykinesia. And people with HD also have reduced coordination. And then this is my red boxes. So I've put red boxes around the things that I think are practically really important and practically useful to know. So the first thing is that people with HD lose their postural reflexes. So that means if they have if they're standing up and they have a bit of a wobble, they won't be able to save themselves. They'll fall over. And that's really the commonest cause of falls, which is very common in Huntington's disease. And the other important point is that the profile of movement disorders change over time, so we need to reassess. And we need to be careful not to overtreat. So this is something that comes up quite commonly, and I can see Noina nodding, so she'll bear this out. The earliest sign of Huntington's is very often really mild chorea, and it looks like someone's just got the fidgets, really. And family members will often pick up on that, and as doctors we'll often see it and pick up on it too, but patients themselves very commonly aren't even aware of it, and it really rarely bothers them if they are. So it's really a useful thing to know that if somebody has chorea, if they're a bit twitchy, they don't need any treatment or any treatment of that. They can be reassured. Treatment is only needed if it's starting to really bother a patient, or if it's causing problems with things like trying to wash yourself or carrying out daily activities. So the next part of that is the cognitive disorder. So the term for the cognitive disorder that we get in HD is a subcortical dementia. So very broadly, you can divide dementias into two types. You've got dementias known as cortical dementias, classically like Alzheimer's disease, where there's a very specific bit of the brain cortex that's predominantly affected, like the memory system in Alzheimer's, and it causes a very specific set of cognitive symptoms. Subcortical dementia is a bit different. It comes from the deep inside of the brain being affected, which is what happens in Huntington's, and it causes symptoms that are quite hard to isolate at the onset. So early cognitive problems in HD look like someone being a bit less cognitively sharp, not being able to concentrate as well as they used to, not being able to multitask. And I've got here another red box. So if you think about the symptoms that you experience or the cognitive effects of just being generally brain overloaded, if you're really stressed out, they're exactly the same. And if you imagine someone who is a pre-manifest HD gene carrier who is worried about developing manifest symptoms of HD, you can see that it's quite common for them to develop similar symptoms. So we would never dismiss these symptoms. We'd never say, oh, go away and don't worry about it. But we're also always really careful to talk with patients and families about not over-interpreting. It's very hard to distinguish very early HD cognitive symptoms from general brain overload symptoms. Over time, cognitive symptoms do become more severe and they become recognizable as an overt dementia, and they include things like rigidity of thinking, disinhibition, perseveration, and reduced emotion perception. And then psychiatric, sort of third part of the triad. So the commonest psychiatric symptom in HD is apathy, actually. There's a similarity with chorea, with the twitching movements, in that quite often apathy bothers family members more than it does patients. And in the same way, we need to be quite thoughtful about whether apathy is causing a problem or whether it is something that is just bothering family members more. But other common symptoms include low mood, anxiety, irritability, obsessions and compulsions, and then less commonly psychosis. Another red box. So my red box here is around manifest HD specifically. So all of these psychiatric symptoms are actually pretty common in the population as a whole. They're not specific to Huntington's disease. Add into the fact that many people who are Huntington's disease gene carriers will have grown up in a family where one of their parents has HD, which is a really challenging and quite a traumatic experience, which in itself is potentially a risk factor for mental health disorders. So I think an important thing to know is that when we think about psychiatric symptoms in relation to Huntington's disease, we only ever attribute them specifically to the Huntington's when someone has manifest HD. Psychiatric symptoms in pre-manifest HD gene carriers are not treated just the same as psychiatric symptoms in anyone else. If somebody needs secondary care input, it would be done through a community mental health team. And if there are questions around that, we can certainly talk more about it in the questions later. But it's quite important to distinguish between that, and broadly to know that there aren't any that really treating psychiatric symptoms in general in people with HD is very similar to treating them in the population in general. A special note on suicide. So I don't want to labour the point too much, but I do think it's important to know that suicide is relatively common in HD. So approximately a quarter of people who carry the Huntington's disease gene will express suicidal thoughts at some point. And a relatively high proportion of people expressing those thoughts will go on to commit suicide. So a study a few years ago gave the incidence of a 5 to 10% suicide rate amongst people who have Huntington's disease. I think that's relatively high. It's higher than we see in our group of patients. But I think whether we agree with the exact numbers or not, certainly suicide is something at which people with HD are at higher risk. In my second red box on that slide, I have impulsivity. So this is really important. So a big reason why there's a relatively high transition from people having suicidal ideas to completing suicide is that impulsivity is very common in HD. And so people who have suicidal thoughts are very vulnerable to an impulsive action, making them going on to commit suicide. And there are a couple of peaks at which suicide is particularly common in the disease process. So they're where those red stars are at the bottom of the slide. So the first peak is when people go from being asymptomatic gene carriers to starting to develop soft signs of HD. And you can imagine that, the thought process is, oh no, it's starting, this is it. The second peak is when people go from stage 1 manifest disease to stage 2. So what that means is when people go from having signs and symptoms of Huntington's disease, but still being relatively independent in their life, to when they're moving to the point where they're losing their independence. And I think you can sort of understand why that might be a second peak for suicide. Now, I think the reason to know that is that any suicidal ideas or thoughts being communicated in someone with HD or carrying the HD gene needs to be taken really seriously and referred on for further assessment. There's no magic solution here, that people need support and it needs to be taken really seriously and really urgently. And then coming to sort of metabolic and compound symptoms. So these are symptoms that don't fit strictly into that sort of triad of the main symptoms. Sleep disturbance, weight loss, swallowing problems, sleep, speech problems, and incontinence are all very common symptoms of HD too. So what can we do? Well, there are loads of things that we can do to help. And this was me brainstorming and writing down off the top of my head lots of different things that I can think of. And there are lots of different things. But as you can imagine, it can feel really overwhelming trying to navigate all of this. I think it feels overwhelming as a healthcare professional trying to navigate this. Trying to navigate it as a patient or a family member is, it's a stage above that. And this schematic was drawn by a family member of a patient with Huntington's disease, and he was trying to convey the absolute mind-boggling nature, really, of trying to juggle everything, the different services that can be involved in giving care, all the different symptoms and the factors that need to be taken on board. And the details of that are less important. It's more the general feeling than the sense that conveys. I think it's really, really difficult and it's really overwhelming. So how do we go about trying to pull that apart and find some ways to address managing HD? So the first thing I would say is that patients, families, and carers are an integral part of the team. I mean, that's the case in being a doctor or a healthcare professional in general, isn't it? That's not news to any of us. But I think it really comes to the fore in HD management. And that's very much because of the nature of HD, because people come from HD families and people are painfully experienced in having to manage HD, and they have a lot of hard-won expertise very often in how to manage things. The second thing is that access to healthcare is really challenging. And part of that is navigating the system in general. It's not straightforward, is it? But some of the HD specific issues are around communication, for example. So HD affects communication. It's hard for patients to pick up the phone and request an appointment, for example. And another red box issue is it's very, very common for patients, particularly with early prodromal disease, to tell healthcare professionals, social care professionals, that they're absolutely fine. We hear this really commonly, that a social worker might phone a patient and ask them if they need any extra support. And patients will say, no, I'm fine, I don't need any help at all. But if you talk to their partner or family member, there's a completely different story. So a patient saying that they're absolutely fine quite often needs a little further examination and a conversation with family members and carers as well. The next point is that none of us can provide optimal care on our own. Huntington's is a real exemplar of a condition that needs a multidisciplinary team, and it needs to cross sectors. And really, that team can involve any or all of the professionals in my slide, a couple of slides above, but you in general practice will always be central to that. And you don't need me, a hospital doctor, telling you in general practice how central you are to healthcare. One thing I would say is that patients and families report that having a named GP, where it's logistically possible, makes a massive difference. So I am mindful of all the logistical challenges within general practice. I have a feeling that probably your side as well, where it is possible to have a named GP being the point of contact for patients with HD, I suspect it does, where possible, make life more straightforward in general practice also. With regard to hospital services, people with HD tend to be seen by genetics, neurology, or neuropsychiatry services. But it's important to note that there are secondary and or tertiary specialist Huntington's disease services that cover the whole of the UK. So if you have a patient with HD or at risk of developing HD because of their family history, and they're not under a specialist HD service, and you think that they would benefit from that, there will be a service to which you can refer them. And it's often a very good idea. I mean, I would encourage that. And then the other group of professionals to flag up are HDA care advisors. So again, it might be something that comes up in questions, but Huntington's disease care advisors sit within the Huntington's Disease Association, and they're fabulous. Essentially, they are experts in Huntington's disease who can support anybody affected by HD, and they cross community and hospital boundaries and are phenomenally valuable in managing HD. So the questions that I would consider when managing symptoms: first of all, some broad principles. Is the symptom due to HD? Stating the obvious here, and no, but people with HD get other conditions too, of course. Secondly, is the symptom actually a problem? So alluding back, for example, to those patients with very early career, does it actually need treating? And then the third thing, is something else triggering the symptom? Is it actually the trigger we need to be considering? So, for example, agitation can worsen all the symptoms in HD. A change in environment, so a new carer, for example, can exacerbate symptoms. Hunger, weight loss, poor sleep, medication changes, all of these things can make everything else worse. The next issue, do we need to consider capacity assessments? We don't always have to consider that, to be questioning that, but a patient, for example, who says there's no problem here at all, but is in a dangerous situation as a result of their HD, does trigger a question around their capacity to make that decision for themselves. And then for patients with more advanced disease, do they have an advanced care plan that perhaps relates to some of their symptoms that might guide management? And then the general principles of treating HD. I would start always by addressing any triggers that might be worsening things. I would do a risk assessment around the symptoms. Are they actually something that is dangerous versus something that's irritating? I would always consider a package of care. Is the current package of care sufficient? And are family and carers getting enough support? And then I am very mindful that I'm talking about symptom control, and actually I'm spending less time talking about very specific things like drugs. And the reason for that is that that's absolutely something that I think specialist services should be leading on. So drugs do have a role in treating some of the symptoms of HD. I'll briefly run through them, but actually this is exactly where specialist services should be leading and guiding. Behavioural management is massively important in Huntington's disease. Again, this could be a webinar in itself. There are some amazing resources on the HDA website around that. And then another thing that's really important is it's often incredibly useful to refer onward to other teams, such as neurorehabilitation teams in the community, CMHTs, palliative care teams. And a final note, in primary care, if you're not sure, please contact HD Specialist Services, because that's exactly what they're there for, and we would always be delighted to get involved. That's kind of what we're meant to be doing. So I've put these slides in not because we have time to go through them now, because I know we don't, but because the slides will all be available to you afterwards, and there's a sort of an overview of some of the symptom specific things that we can do for some of the specific symptoms. So I'm going to skip forward now to information sources, because I think that's always the most important thing, isn't it? Where can we go to get information? So the main things that I would recommend is firstly the HDA website. It has got so much accessible and reliable information, and it's great for patients, for family members, and also for healthcare professionals. Secondly, HD care advisors are full of knowledge and really experienced in managing HD. Thirdly, HD specialist teams are here for exactly this. And then finally, there's a website called HD Buzz, which is all about HD research. And for those of you who have patients who have HD or HD families, you will find that a lot of your patients and their family members will be following HD Buzz. So it's quite useful to know about it and just know that's something that they might raise. So I think I'm going to pass over to Nayana at this page. Yeah.
The aim of this part of the talk is to talk about the genetic basis of Huntington's disease. So Marianne's given us a great introduction into what the condition is and how it affects patients and their families. But it can be helpful to understand why it happens, how the genetics relate to the features of the disease, what the difference is between diagnostic and predictive testing, which are questions that you might be asked by patients and their family members. Just to give you a very brief outline of the family planning options, because again, these are questions people might come to you as a first port of call for. Huntington's disease is caused by an expansion, a triplet repeat expansion in the HD gene. And so everyone has 2 copies of the gene, and if you are at risk of developing Huntington's disease, you will have 1 normal copy of the gene and 1 changed copy of the gene. And so that is an autosomal dominant condition. So if you do have the condition when you come on to have children, or if you carry the expanded gene when you come on to have children, there is a 50-50 chance of either passing on the normal copy or passing on the changed copy to any children. So we know that, whilst the incidence of Huntington's disease is around 1 in 10,000, there are many, many more people at risk of Huntington's disease because there are people who carry the gene who are not yet symptomatic. And so Marianne has already discussed how Huntington's disease happens. And I suppose in clinical genetics, we think about this phase here as being the pre-manifest stage, or people who might be at risk of developing symptoms but haven't developed symptoms yet, and people who have had a clinical diagnosis or a prodromal as at the time when you might think about a diagnostic a diagnostic test. And it is really important to think about this area because a lot of the therapies that are in development at the moment are sort of targeting people who are very early or just about diagnosed with Huntington's disease. There are clinical trials that are trying to lower the HD gene, which would sort of bring this line up so that you might be able to extend out the time at which people can remain functioning well. And as we go on, those trials might become earlier and earlier in the disease process. And so the ultimate aim is to try and shift this line down so that we are keeping people healthy for longer. And the gene was discovered because of families. So the families are hugely important. So this is Nancy Wexler, and the HD gene was identified after an enormous international collaboration looking at patients and looking at families and sort of trying to trace the gene through the families. And so HD patients and family members have been hugely important in research into developing, so identifying the gene, but also into developing the sort of the therapies that are in clinical trials at the moment. So what do you need to know about genetic testing for HD? Well, it's just a blood test. The blood test goes to a specialist laboratory, and there are the genetic laboratory hubs in England, and there will be genetic laboratories in the rest of the UK that will accept samples for genetic testing from particular specialists to carry out genetic testing for HD. And the genetic test counts the numbers of the CAG triplet repeat expansion on each copy of the Huntington's disease gene, and then it gives us two numbers as to what the expansion number is, and that will tell us whether or not somebody is at risk of developing Huntington's disease or not. But that test is a test that you can have it could be taken at any point in somebody's lifespan. So knowing what the genetic test result is doesn't really tell us when symptoms might start, doesn't tell us what the symptoms are going to be, and it doesn't tell us how the condition is going to progress over time. And so if you were to see somebody in clinic who is symptomatic with Huntington's disease, that will be from two different aspects. So one is somebody who is symptomatic and who has a clear family history of Huntington's disease. And in those cases, we would suggest that in the first instance, you could refer to an HD specialist service if there is one local to you or within your area, or you could refer to clinical genetics, or you could refer to a movement disorder specialist. And any of those people would be able to do a confirmatory test to see if that person does have Huntington's disease, and then sort of institute appropriate management or onward referrals. That is done via a single gene test, so just specifically looking at the HD gene to see whether or not there is an expanded copy of the gene, and the results take about 6 weeks to come back. There are some reasons why you might want to extend that process. So very much so in the prodromal period, people might not know that they are developing symptoms or might not quite have come to terms with that. And so sometimes genetic counselling, particularly referral to clinical genetics rather than to a movement disorder specialist or an HD specialist, might be your best port of call. But any of those people will be able to advise appropriately and hopefully make sure that the testing was done in an appropriate fashion with the appropriate psychological support. Then you might see somebody who is symptomatic, has a movement disorder, looks like chorea, has some of those other features that might be indicative of Huntington's disease, but they don't have a family history. And this accounts for about sort of 10% of people with Huntington's disease because the family history is not known for any reason. Sometimes HD families can be chaotic, and so there have been rifts in the family, or information might not have been shared in the family, or because this is something that has occurred for the first time in that family. And if you saw somebody with chorea with some other features, and didn't have a family history, then we would usually advise that the port of call would be to a movement disorder specialist rather than to an HD specialist service, or to a neurogenetics or a clinical geneticist to sort of think about what other testing might be appropriate. Other investigations like an MRI brain scan or other biomarker tests, as well as genetic testing, might be appropriate in those circumstances. And so the testing could be done via a single gene test, the results of which come back very quickly, or some people might not have that test because it's not clear that it's Huntington's disease. And now we have whole genome sequencing that will look at a number of different genes that can cause a number of different features. And the results of that can take a lot longer. And of course, a result in somebody who doesn't have a family history might have, additional psychological impact, and also obviously will open up a can of worms for the rest of the family. So as I said, there's a no family history in about 10% of people with Huntington's disease for a number of different reasons. And there are also some conditions that can look like Huntington's disease, but it isn't actually Huntington's disease. It might be due to a different genetic condition or a non-genetic condition. So sometimes medication-induced chorea or functional neurological disorders can overlap with some of the features that we see in Huntington's disease. So when you're thinking about diagnostic testing, that can be done by a neurologist, a psychiatrist, or a clinical geneticist. But it's important to remember that the HD diagnosis is made clinically based on the features that Marianne has outlined. It's important to know there are different ways of doing that test, and that can take different lengths of time for the result to come back. It's important to think about the experience and the knowledge of both the family who are having this test, but also the clinician who is doing the testing, and because that can affect the way that the results are communicated to the family. There are sources of support, so you're here because you know about the Huntington's Disease Association, but there are also additional sources of support through the HD services themselves. And it's really important to remember the impact of a diagnostic test result on other family members and how that's going to be communicated and what onward referrals might need to be made after that. So when we get the results from an HD diagnostic test, usually it will tell us that somebody has more than 40 CAG repeats, and that is an HD causing genetic change. And the higher the number of repeats, in general, the earlier the age of onset tends to be. So if somebody has over 60 repeats, that makes you think about whether or not someone might have juvenile onset Huntington's disease, or Huntington's disease can occur any time in someone's time in the timeline. So from childhood onset all the way up until onset in the 70s, and the CAG repeat size tells us something about when those symptoms might start, but it doesn't tell us everything. And this really sort of communicates that. So this is the CAG repeat size, the length of that expanded CAG repeat, and this is somebody's age. And so we know that there are some people with these what we call reduced penetrance alleles, so 38 repeats is below the threshold, that might develop symptoms, but may not develop symptoms depending on how old they are, how long they live. But somebody with 42 repeats, we would expect about 50% of people to develop onset in their 50s, but actually onset, you can see here, can be as early as in the 30s and up to here somewhere in the 70s or 80s. And so it is really variable. So whilst the CAG repeat size gives us some information, it doesn't give us all of the information, and that can come with a lot of uncertainty to people within families. So I've already mentioned reduced penetrance alleles, so where some people may never develop symptoms. And we know that there is also this intermediate allele size where people we wouldn't expect to develop symptoms, but there is just a theoretical risk that when people with an intermediate allele come on to have children, that there is a risk of passing an HD causing allele on to offspring. So for reduced penetrance alleles, the higher that number is, the more likely it is that somebody is going to develop symptoms, but symptoms tend to be later on. For intermediate alleles, they don't cause Huntington's disease. They are relatively common in the general population, and there is a theoretical risk that they could expand into future generations. And so it is a complex area, and referral to a clinical geneticist would be appropriate to discuss those risks. So we know that Huntington's disease impacts families, and there is some evidence that the age of onset of Huntington's disease tends to decrease through the generations. And we always used to think about genetic anticipation in these families. So, there's something about the gene that means that people when it gets passed on, it comes out earlier and earlier and earlier. But that's not necessarily the case. And often the CAG repeat expansion remains stable through the generations. But actually people might be diagnosed earlier because they know about it in the family, and so they're looking out for the very earliest signs. And so where somebody generations before might not have sort of attributed those symptoms to Huntington's disease and diagnosed late, people now who are watching out for symptoms might be diagnosed with Huntington's disease earlier. But there are some families where the repeat size is unstable and the repeat size can get bigger between generations, and that could also lead to genetic anticipation. That's because DNA replication mechanisms can add in a few extra CAG repeats when they are passed on, and that might depend on a genetic background, and it might depend on the sex of the parent who carries the HD gene. And so we know that people with juvenile onset Huntington's disease are much more likely to have inherited it from a father rather than from a mother. And that doesn't mean that expansions can't occur from either sex, but it's more likely that it'll expand greatly from a father than a mother, but most of them stay the same. So what is predictive testing? So predictive testing is doing a test in somebody who hasn't got symptoms of Huntington's disease, but is at risk of developing it because of their family history. And before this test was available, there was a survey done of family members, and about 80% of people said that, if we had a test available to us, we would want to take that test. But over the years, and we've been monitoring this through something called the Predictive Testing Consortium in the UK, it is very consistent that only 20% of people at risk of Huntington's disease decide to have predictive testing, and only a few more than that come referred to clinical genetic services to discuss it. So there are lots of family members out there who choose not to have a test and who choose not to sort of come to a clinic to discuss their risk. And because of this increased suicide risk, and because of the uncertainty around when symptoms might start, and because of some of the issues related to insurance and other things, genetic counselling is important when somebody is thinking about having predictive testing. And predictive testing should only be done in clinical genetic services at the moment. But there are 23 regional genetic services in the UK, and many of them have local outreach clinics, and so there should be a clinic close to you that you would be able to refer somebody to. And we carry out genetic testing, pre-symptomatic testing, according to internationally agreed guidance, which means there should be a number of appointments to help people to make a decision about when is the right time for them to have a test. And there should be support following a predictive test. And so these are just some risk factors that we think about when so most people, have a test, and they are well supported, and they have they have very good reasons for having testing, and it's their information anyway. And so with the right support, anybody should be able to have predictive testing. But there are some cases where it just takes a little bit more thought, and we might sort of think about involving other people within that process, and these are the risk factors for where we might need to sort of put a little bit more in place in terms of support for people having predictive testing. So what are some of the things to think about? Well, HD families, as we've already said, can be complex, and some people might come to us as not the person who is directly at risk. So where there might be a grandparent who is affected, and actually the parent has chosen not to have genetic testing, but now a young person or somebody who is thinking about starting a family might come to see you to discuss their HD risk. And so there are complex family situations, and all those people should be able to access support or a referral to clinical genetics to discuss their risk and their options. And so it is possible to do testing in all sorts of situations, but it has to be done with some additional thought. It's important to think about the psychological impact on the people and also on their family and where they might be getting support from. Predictive testing often sort of just replaces one uncertainty, which is, have I inherited the gene or not, with a whole number of other questions about what's going to happen, when the symptoms are going to start, what they're going to be like, and then sort of living at risk becomes a real, becomes the uncertainty that people are living with. So a predictive test doesn't always solve all of the questions that people might have, but it is really important for family planning, and we'll come on to that in a moment. And there are, observational research studies for anybody who is at risk of Huntington's disease that might help with that support, and also might be an alternative to a genetic test if people don't feel like they are ready to receive that absolute information yet. Some of the things that people particularly ask about is employment. And so you'll know that there are sort of the Equality Act means that people shouldn't be discriminated based on genetic risk or any other sort of protected factors, but there are some careers, so particularly in the army, that people might be asked to have a predictive test before they enter. Whether that is right or wrong is a completely different question, but some people might run into problems because of their genetic risk. People often ask about driving in the DVLA, and so you don't need to tell the DVLA if you have had a pre-symptomatic test for Huntington's disease, but if you have been diagnosed with clinical symptoms which are related to Huntington's disease, then you do need to notify the DVLA. Lots of people with early HD drive for a number of years, but they have to have an annual DVLA update assessment outlining whether or not there has been any symptomatic change, and might be asked to do a driving test at some point to confirm that spatial awareness and cognitively that they're able to continue driving. The best time to talk about family planning is well in advance of starting a family. And so if you see family members who are worried about their risk or who would want to do something differently, then please refer them to your local genetics clinic to have these sorts of discussions. And the main options are to not let HD influence their reproductive decisions, and that's what lots of people choose to do. But there are obviously some people who would choose not to have a child who is at risk of Huntington's disease if it's something which is within their control to do. And most couples, that would look like pre-implantation genetic testing, which is a little bit like IVF with the added step of doing a genetic test. Or for some people who that is not a possibility for, people might have a test in a pregnancy. And so for pre-implantation genetic testing, there is up to 3 full cycles until a successful pregnancy that could be funded within the NHS in England. But there are some certain criteria that people need to meet. And so that is based on the female partner's age, whether or not they are at risk of Huntington's disease or not, the female partner's BMI, and then some other factors which I've listed here below. And the main one is actually that can sometimes cause a barrier is that if there are any existing children from that relationship who may or may not have been tested, so somebody finds out that they're at risk of Huntington's disease after they have already had a child, then they would not be eligible for NHS funding at the moment for pre-implantation genetic diagnosis. And then prenatal diagnosis, we would do a CVS or an amniocentesis. Usually we try and do a CVS early, but of course that comes with a small risk of miscarriage. and the added step of a couple having to make a decision about whether or not they would like to end that pregnancy if it were to show that the pregnancy were at risk of HD. And so it does need some thought. And it's, as soon as we say to people, as soon as you find out you're pregnant, if this is something that you want to think about, then, be referred to your clinical genetics service, even, before your dating scan or before your first trimester scan, so that we can start having those discussions early and to plan. And it is also important for you to be aware that there are ways of us doing pre-implantation genetic testing or a prenatal test, even if the person who is at risk of Huntington's disease hasn't had a genetic test themselves. So that's by exclusion testing, where a person at risk hasn't had a predictive test, but has a parent who is affected with Huntington's disease. And we can do that not giving away the status of that parent, so they wouldn't inadvertently get a result from their genetic test. I won't go into this, but this is how it is done. It's by tracking chromosomes through a family rather than by doing a direct HD test. So there is a potential risk that you will be excluding embryos that actually were never going to be affected with Huntington's disease, or ending an unaffected pregnancy. I hope that we've highlighted that HD is complicated, and I'm sure that those of you who have got patients and families who are affected by HD already know that. But that, hopefully this has given you some information about people's choices and pathways for care and how to manage things.
Yeah, so there's a question there, Marianne, about sleep disturbance. So someone's asking, is sleep disturbance related to movements, or is there another mechanism?
Yeah, it's a really good question. So first of all, sleep disturbance is really, really common in HD and also in pre-manifest gene carriers. So we see the sleep disturbance happening even in pre-manifest gene carriers. It's not usually related to the movements. By the time people's movements are enough to disturb sleep, it's quite a sort of late stage thing. It's due to disturbance in the sort of endocrine and metabolic pathways that the actual sleep pathways itself is impaired. In terms of what is helpful, melatonin, I mean, it's such a discussion, isn't it? So it's a sort of quite a 2024, 2025 about a conversation around melatonin. Melatonin is really, really helpful for a lot of people with HD. And even for people who benefit from melatonin, even small doses, a couple of milligrams can be really transformative for people with HD. So melatonin mimics, it's sort of a mimic of the natural hormones that we produce to make us sleepy and go to sleep. And a lot of people in HD just won't be producing that. Melatonin replaces that. It's really well tolerated. I don't think I've ever had a patient actually who didn't tolerate melatonin, and it can be continued as long as needed.
Marianne, I think we've got a question here about olfactory hallucinations. So someone's asking, are olfactory hallucinations common in HD?
And they're not actually, although I suspect that there are some people who get those sort of olfactory hallucinations or sort of pseudo hallucinations, weird sensory experiences, and I suspect that it probably is something that, given everything else that's going on, quite often doesn't get reported, but it's not a common symptom of HD. But I think it's really interesting. So you mentioned the patient that you had. If I was seeing this patient and trying to pull it apart, I suspect that there may be an olfactory hallucination, but there's probably also people with HD tend to get quite stuck on ideas. There can be a bit of a fixation, there can be ruminations, there can be perseveration, and the devil's in the detail a bit. So with people who've got these odd sensory experiences, it's usually a combination of things. So there's this perceptual experience, the hallucination or pseudo hallucination, but there's also the perseveration, the sort of getting stuck on an idea that's feeding into it. And a patient like your patient, I think, would be an excellent candidate to be reviewed by a neuropsychiatrist or be reviewed in an HD service specifically to try to pull that apart, because potentially that there could be some sort of benefits around different medications for that. the other thing as well, which I suspect your family members have already tried, and it's challenging, but redirection of attention. So having ways that if the person with HD starts to get quite stuck on that idea, then trying to redirect attention, but it's not always easy. But that sounds like a good reason to refer someone to an HD service to pick that apart a bit more.
Nayana, we've got a question just about, I think I'm asking for a bit of clarification about twins and about the different types of twins, the differences in terms of the genetics there.
Yeah, so twins is a tricky one. So even if somebody is a dizygotic twin, so a presumed dizygotic, as in there were two amniotic sacs, then we know from genetics experience that they aren't always non-identical. So there's lots of different ways it's difficult to know monozygosity or dizygosity just by knowing what the structure of the twinning was. And of course, we wouldn't want to inadvertently give a twin a result for an HD predictive test, and so it is important to think about it a little bit more carefully, and sometimes we might take twins through predictive testing at the same time, or at least have those conversations to make sure that everyone was on board. Sometimes we might do zygosity testing before, and if they were dizygotic, then we can split the processes. But it just needs a little bit more thought. Everyone should have a test. If they want to have a test, it's about sort of how to best manage that so that everybody gets the outcome that is the best outcome for them.
Great, thank you very much. So someone's asking, is genetic testing available for preconception and selection of embryo if the parent doesn't want to know if they're a carrier of HD?
Yeah, so exclusion testing is available for some couples, but there are particular things that need to happen. So there have to be enough informative samples from other people in the family. So it does need some communication with other people in the family in order to be able to do that tracking of the chromosomes through the family. So say I was at risk of Huntington's disease, but I didn't want to have a predictive test, and I did want to have pre-implantation genetic testing that would mean that I could have an IVF pregnancy that wasn't going to be at risk of Huntington's disease. We would need samples from the father, and we would need samples from both of my parents in order to track the chromosomes through to make sure that my result was not disclosed. I hope that makes sense.
Thank you very much. We've got one last question here. So someone's asking, is testing available to under 18s with a higher risk of juvenile onset, i.e. genetic anticipation?
Yeah, so yes. So there are predictive test recommendations, and recommendations are recommendations, and there are always going to be situations in which testing outside of recommendations is the right thing to do, but it needs to be taken thoughtfully and carefully, those decisions. And so if there was somebody who was under 18 who was in care, or where support might actually be better, whether if they were tested under the age of 18, or where there are concerns about symptomatic juvenile Huntington's disease, then we might want to do testing under those circumstances. What we don't want to happen is that somebody inadvertently gets a result that actually isn't showing that they have juvenile Huntington's disease, but is giving them a result that shows that they're going to develop symptoms in their 30s or 40s or 50s or 60s, because that can be a really, really difficult situation for people to to manage. And so if we were going to do a test for somebody under 18, it has to be based on symptoms that could be juvenile Huntington's disease, and that looks slightly different from adult Huntington's disease.
Thank you very much, Nayana. All remains is for me to say thank you very much to Marianne and Nayana for their time this afternoon. Hope that people attending have found that helpful, and just to say thank you to everyone who's attended today and for taking the time to come out and find out a bit more about supporting people in families where there's Huntington's. We appreciate your time.